recorded presentation?
Yeah, sure. Please go ahead.
We are waiting for his presentation even in the last conference.
Yes.
Yeah, I could not come, so I sent my video recording.
It's okay.
So the same thing
I'm
there.
also interested to listen to you.
Thank you. Thank you.
Most
Okay, then.
welcome.
Hello, everyone, and my apology for yesterday. And I sincerely thank to Dr. Ajad and Dr. Kamal and all the organizers of this meeting. I wish I would have been there, but because of some circumstances, I could not come. But I always love to come to Bangladesh, Dhaka, and Chatgaon is on my bucket list. Hopefully, I'll make someday there. My topic of today is approach to the renal masses. As you see that there are the benign renal masses, you can see simple cyst to angiomyolipoma, and there are others like XGP and infected renal cysts. There's a huge list for benign renal masses, and then there is a huge list for malignant renal masses also, like RCC. RCC itself is multiple type of RCC. Now you can see that from existing from clear cell carcinoma to multilocular cystic clear cell carcinoma, papillary, chromophobe, hybrid, oncocytic, medullary, mucinous, so many things. Then there is nephroblastic tumors, nephrogenic rest, nephroblastoma, carcinoma associated with neuroblastoma, and then metastatic carcinoma tumor in the kidney. They can present as malignant renal masses. Presentation, if you see in 1980s when I was trained in as an MBBS student, we were taught that the three things, that flank vein, visible hematuria, and palpable mass are the key features for their pathognomonic of, this is the classical triad for RCC. And it used to be in more than 50 to 60% of the patients. But now you can see that in 2022, by Ballard, it is 6 to 10% only. And now they present aggressive histology, advanced disease, and poorer outcome. If you have these three triad, the patient is for doom. He will not do well. And the 30% of the patient can have paraneoplastic syndrome. This is also used to be in past. Now we do not see such cases. More than 50% of the cases, what we see is incidentally detected RCC or kidney mass for something else. They are done for urinary symptom, for pain in abdomen, for some maybe for unspecific complaint. And then you see there's a tumor sitting there. And that is why there is a separate entity has come, like small renal masses, SRM, where the debate is to treat or not to treat. Now the other metastatic disease, if the metastatic disease is there, patient can present as bone pain, persistent cough, and sometime with the epileptic fit also. With the there is a patient can present just a epileptic fit, and when you do MRI, there is a tumor sitting in the MRI in the brain, and then when you investigate for primary, there is a tumor in the kidney. The history one has to take for smoking, tobacco, hypertension, gross or microscopic hematuria. You must talk to patient about flank pain. You must palpate if there is abdominal mass or not. It is palpable, bimanually palpable, ballotable. Jaundice sometimes can occur when it is advanced disease, cough of recent onset, and the bone pain. Physical examination, pallor, sometimes patient can have anemia. Icterus can occur in advanced disease, but one should always look for supraclavicular lymph node if they are enlarged, because they get involved frequently. Palpable abdominal mass, as I have told you, bimanually palpable, ballotable, non-reducing varicocele. This is another very important sign, especially on the right side varicocele. If it is there, if you see any young patient with the right side varicocele, you must do ultrasound abdomen. He may be having the kidney tumor or maybe having IVC thrombus or something else. Then bilateral lymphedema can occur to these patients who have advanced disease. Radiological approach for these patients is, if you suspect or detect any renal mass, you can see that in ultrasound it can be divided into complex cyst or solid mass, or it can be just a simple cyst, which can be observed. One should not do anything for cyst like this. But if the patient has got complex cyst, then you see the contrast allergy. If he has got no contrast allergy, then you see the EGFR more than 45, 32, 45 or 40 less than 30. If there is significant contrast energy, then he goes to MRI with or without gadolinium. But if he does not have the contrast allergy and the EGFR is more than 45, straight away you can do the CT scan, which is very informative. And as a urologist or as a surgeon, you can actually see the CT scan, can read the CT scan, but not MRI. If EGFR between 30 to 45, then you have to do the peri-procedural hydration and then do the CT scan. CT gives you lots of information, as I've told you, the characteristics and differentiation of renal masses, guide next line of investigation. Sometime you may have to do bone scan or PET scan. Nowadays we do PET scan. Extent of the tumor thrombus, CT angiogram can give you how many renal arteries are there in this patient. And then you have 3D reconstruction, which you can use the augmentation reality. Nowadays we use in robotic for doing the partial nephrectomy. These are CT scan, and there are phases of CT scan, like non-contrast is pre-contrast, then early arterial is 20 to 30 seconds. This depicts the artery and the relationship with masses. Then corticomedullary phase, 40 to 70 seconds, subcategorizes the RC. You can see that is oncocytoma or something else, or papillary, you can detect on CT scan. Then there is a nephrogenic phase, which enhances the component in the masses. Then in the excretory phase, which is after 5 to 10 minutes, this gives the relation of mass with the PCS. There are indeterminate mass with like non-contrast or nephrogenic, they can be detected. And before partial nephrectomy or active surveillance, you must do additional arterial phase or excretory phase for these patients, where you can actually define the anatomy and then you can plan the surgery or the active surveillance. Simple cyst on CT scan looks like this. You can see the well-defined, well-marginated mass, well-homogeneous and heterogeneous enhancement. These are suggestive of oncocytoma. Their central is slate, non-enhancing scar. 1/3 of cases, these will be oncocytoma. Then there is a presence of macroscopic fat. These are classical angiomyolipoma, and this is the enhanced solid mass. This is a classical of RCC. Then renal masses on CT scan, you can divide non-enhancing cyst, as I showed you already, macroscopic fat, angiomyolipoma, I've shown you. Then enhancement, no fat, it can be RCC or other tumor. If the equivocal enhancement 10 to 20 Hounsfield speed, then low enhancing lesion or pseudo enhancement, they consider MRI in these patients. If there is a mild enhancement, then RCC papillary most likely, or differential diagnosis, oncocytoma. I have shown you the picture. These are the surgical candidate, and you can operate them. And there's the vivid enhancement. There's the RCC. They are actually for the surgery. Ball type lesion are classical of renal cell carcinoma, angiolipoma, oncocytic tumor. This can be anything. Ball type of lesion. There is a bean type of lesion where the contour of the kidney has not changed. These can be the renal cell carcinoma. This can be lymphoma, metastasis, infection, infarction. Ball type of lesion are most common, and they actually expensile and they deform the renal contour. While, as I've told you, bean type do not change the contour of the kidney. Then the bean type of lesion, this can be divided into centrally infiltrative lesion, filling the pelvis or PCS. This will be generally urothelial carcinoma like this, TCC. Then is in a young patient, sickle cell disease, infiltrated lesion. It can be medullary RCC like this. Then there can be multifocal, bilateral, diffuse involvement, other organ involved, lymphadenopathy. This can be lymphoma. There is a pain and signs of infection. Then it can be pyelonephritis, or sometimes there is a wedge-shaped lesion, which is like this. There can be an infarction. This is pyelonephritis. These are metastases. These are lymphoma. So these are the things which you can know on the CT scan. Next is the renal vein thrombus, and they are divided into level 1, just into the renal vein, level 2, infrahepatic IVC, level 3, intrahepatic IVC, and level 4 into the atrium. And then they can be further subdivided into 3A into the intrahepatic, 3B is hepatic, and 3C is the suprahepatic. So this can be easily, one can diagnose on the CT scan. The deep learning and automated diagnosis of RCC is subtype can be actually now done by AI, using AI. One can say that they can be classified into clear cell, papillary, chromophobe, AML, oncocytoma. This paper was published in Precision Oncology, and this is the work is going on. Maybe in future we'll be having more and more subtype which can be detected on imaging. That is actually the future. Now coming to CT angiography, you can see the CT angiography can tell you about the vasculature part and arterial mapping, and maybe we need it especially for partial nephrectomy. 3D reconstructive model is used in the complex partial nephrectomy, and they are available in India. And this doesn't cost much, except probably 8,000 per case. And this is very useful while you are doing complex partial nephrectomy. Cyst classification, I can mention that there's a simple benign. Bosniak 1 is simple benign. Bosniak 2 is again taken as benign, and this can be, there is some septa. The 2F requires follow-up up to 5 years. Some are malignant. One has to be careful in 2F. You have to tell that patient has to come regularly for checkup. Bosniak 3 are indeterminate cystic mass with thickened irregular walls, septa with enhancement, and then there is a surgery or active surveillance. Over 50% of these patients are malignant. And then Bosniak 4 is clearly malignant, and they should be having the surgery. MRI has role in renal masses. One can say it is as good as CT scan is concerned, but not used unless you are, there is a contraindication to do the CT scan. Diffusion weighted 1, T1 high and out of phase are used, and they can detect even cyst or abscess, angiomyolipoma, macroscopic fat, proteinaceous or hemorrhagic cyst. T2 can be high and low or ISO in lesion, like including RCC. So one can use MRI, but it's not very popular because surgeon cannot read this, and secondly because they are time consuming than the CT scan. Then there is a Bosniak classification. MRI instead of CT, MRI is better for cystic renal masses. You can see that on MRI, Bosniak 2F uniform homogeneous mild wall thickening. This is the picture of Bosniak 2. This is Bosniak 1. This is Bosniak 2. Again, you can see this. Bosniak 3 on MRI is very well characterized, and Bosniak 4, you can see again one can say with very confidently that this probably is malignant. MRI is predicting in IVC thrombus whether it is involving the wall or not. Invasion of the wall of IVC by the thrombus is very nicely depicted by MRI, which is not very good with CT scan. And the one should use when you're having these type of patient. Then when to do MRI, there is specific indication, as I've told you, when CECT is contraindicated, or there is a low EGFR, or in pregnancy. Equivocal cases, if you see the CT scan is not giving you a clear-cut information, you can use it. Better to extend for the tumor thrombus. In younger patient, concern for radiation exposure, MRI is preferred. MP-MRI for diagnosis of clear cell carcinoma via clear cell likelihood scale also is available, and which can give you very good indication that this is clear cell carcinoma, or better than CT in complex renal cyst, as I have told you in 2F and 3. Laboratory investigation, we know all of these laboratory investigation are must: urine routine, CBC, KFT, LFT, calcium, LDH, serum, chest X-ray. Other imaging which can be done in kidney masses, renal masses, is contrast enhanced ultrasound. In equivocal cases, when on CT, MRI are not clear, you can use this modality. Then CT chest when symptomatic or abnormality in the X-ray chest. Bone scan when the bone pain or significant high index of having the bony metastasis. But the thing which is used nowadays is FDG PET scan format to rule out metastasis. We always do when there is a big renal masses, because it may not enhance the primary. It's not very good for primary, but it is very good for the metastatic disease. Almost more than 90% sensitive and specific. We can know that whether this is metastasis or not. Another role of PET CT is in recurrent RCC. Even the thrombus, we can know the blend or live thrombus is there. Then in the follow-up, if the metastatic disease is there, then in the follow-up, we use FDG PET scan to see the response of disease, whether it is stable or progressive, or it is, it's a functional imaging. So even the uptake, if the uptake of FDG contrast is less, one can say that the patient is responding to the treatment. The other imaging which are used in renal masses is renal scintigraphy, TTP, renal scan, MAG3 scan for deranged EFT, or when you know that where there's single kidney or there's a bilateral tumor or there's suboptimal function, then one can use whether to save the kidney is mandatory, imperative, then one has to use DTP renogram. CT MRI brain for the altered consciousness and focal neurological deficit, as I have told you many times. Tumor most of the time. Another advantage for one should do this when you approach to the renal masses, then one you should do the nephrometry score. There are plenty of nephrometry score, and they actually are used. They use most of the common criteria like radius of tumor, exophatic, endophatic, nearness to the tumor to the collecting system, anterior, posterior, location related to the polar lines, and these, according to them, you can score the low, intermediate, and high, and they give you the complexity in doing the partial nephrectomy. Higher the nephrometry score, this means that the complex partial nephrectomy you have to do, and it is very useful in patients, and it is academically required for all the papers also. You can actually plan the surgery. You can give it to your junior when the nephrometry score is low, and is better experienced surgeon. Are renal mass biopsy is used to I think 20, the came down because now there's a resurgence of renal mass biopsy because the yield of renal FNAC, kidney FNAC, has increased like anything. More than 90% of the time, the pathologist will tell you what type of the disease is. If it is infective, or it is lymphoma, or it is malignancy, or if it is not malignancy, which type of the tumor is there. So, and because of the yield of FNAC has increased, FNAC and FNAB, more and more use of renal mass biopsy has come in the practice. And it has to be done if you are putting the patient for active surveillance or ablative therapy, or if you're not planning the nephrectomy, putting the patients or target therapy or immunotherapy, the biopsy has to be done in these patients. The other indication is that whenever you see the atypical renal mass, it's better to do biopsy before rather than doing straight away nephrectomy, because many times you will find that the patient may be having like lymphoma, may be having metastasis. So just don't jump for surgery in these patients. So better to always do the FNAB whenever you are in a dilemma, because this yield of FNAB is very good nowadays. These are the staging of RCC. We all know T1, T2, T3, T4. I'll not just go. The take-home message is whenever abdominal mass or symptoms suggest of renal masses, proper history and physical examination is must. Accurate diagnosis of nature and pathology is not needed, but then if you have an indeterminate or atypical renal mass, it's better to do FNAB. Otherwise, you can straight away go for nephrectomy or partial nephrectomy if on CT scan it is heterogeneously enhancing mass. Proper radiological tools to guide the treatment option. Okay, one should not hesitate in doing CT angio or augmentation reality or MRI. You can use all modality in a single patient. Use judiciously. Nowadays, these especially so one should not hesitate in these modality. So thanks a lot and for this opportunity.
Recording in progress.
And which will be a great thing for us. Thank you. Bye bye, and have a nice day and nice conference.
Thank you. Thank you very much, Professor Sudhir, for your nice talk. I think it's a lot of informations within a very short time, very precise and focused. So I think any question from the students, then Professor Salam will comment. Any question from the students, please? You can ask any question to Professor Sudhir directly.
Sir, about
Any-
operative procedure, it all the laparoscopy, any other minimally invasive option is available. Just
Yeah, we do routinely robotic nephron sparing surgery. It's rather a very common operation nowadays in any oncological setup. But if the tumor is big, though he goes for left nephrectomy, open nephrectomy, and sometimes the patient is big and a big tumor, he goes for robotic nephrectomy also. So all the modalities we have, and they have to be used depending on the situation, the size of tumor, the heavy, obese patients. In obese patients, robotic is better. But if a thin patient, big, and you can probably tackle with the laparoscopic nephrectomy. Laparoscopic nephron sparing surgery is now not done in most of the places because robotic gives a huge advantage.
Yes. Can I ask a question, Professor Azad, to
Yes.
Dr. Sudhir Rawal?
Sure, sir.
Well,
Sure, sir.
I would like to ask him about the Indian origin robotic system, the mantra. I know you have got one mantra installation at your institute. How you are working and what is your experiences?
We have the mantra. We actually are involved in robot right from the beginning. All the phase 2 phases, first in the lab, and then it came to hospital. So with the mantra one, we did 18 surgical procedure. Genius and everybody find out that this is not make some changes. So they came with mantra 2 surgical procedure, and so we actually bought this. It's very affordable. Cost is less, is capital cost is less. So, but then, as any robot we did have that problem with the mantra. And, but then for last 3 months, there is no problem. UCCon was in January. So in January, they had
incidents of
you're right. So which was put in UCCon, this has gone to Coimbatore. No problem with this robot. There's a software which has been.
Are very, very smart. They have
Yes. Yeah. So I am using it every day, and we are saving money for patients. And it is we do all cases like cystectomies, prostatectomies, nephrological surgery. Then it is already installed at 8 on. They have lobectomy. They have done thyroidectomy. People have done thyroidectomy, transoral surgery.
It's a good piece of information which might by
I'm telling the surgeon, Dr. Sudhir Shrivastava, who made this robot, that you must come with me to Dhaka and change this robot, because there is a huge opportunity in that it is affordable robot, and they are very good surgeon in these Nepal and Bangladesh. They are aiming Nepal, Bangladesh, and Sri Lanka, but they are applying CE mark and FDA. Everything is going together. So it says every 2-3 months they actually evolve into, as it happens with any technology. But as of now, it is matured enough to buy so that it doesn't hang, and you can operate it. So you can do the surgery for 4 or 5 hours continuously.
delivered right now.
Thank you.
This will spread very quickly.
Yes, yes. Dr. Kamal, please.
So I take the opportunity to thank Dr. Awal because at the last part of his presentation, he was inviting that their RGCI is ready to accept faculty to train. So we are so grateful to him that already he has extended his support, and I had developed a habit of not listening with any such proposal. He is always telling yes. So thanks to you, Dr. Awal. I take the pleasure to
You are most
thank you in
welcome,
this
Dr.
platform.
Kamal. It is his pleasure.
And these juniors are blessed with the support that you are extending. And maybe within few days, another is coming to you with proposal of few more.
Yeah, sure. Anytime.
And not only Dr. Azad, it is not only in surgery. He is responding for radiotherapy, pathology, radiology, everywhere. Wherever I am saying, the door is totally open. Even in pediatric oncology, I am now next month, somebody is going for pediatric oncology.
Yeah.
We are so much supporting. We are so grateful. And I hope that you will visit Chittagong very soon also in the next time so that you know Chittagong. Thank you.
Yes.
Thank you. Thank you, Dr. Kamal, and thank you, Dr. Sudhiral. Sudhiral, to you, one question from the students. Is there any role of cytoreductive surgery in RCC?
Yes, there is a debate on this after especially Carmina trial. There's a lot of medical oncologists. They start target therapy straight away, and if the big tumor is there and small metastasis, the classical role of cytoreductive nephrectomy as of now nowadays is when the primary is the bigger mass. So, a big primary tumor with a small metastatic tumor. One condition is this. Second, if the patient has hematuria, third is got pain, local symptom is there, then patient has to have cytoreductive nephrectomy. But I will not hurry for cytoreductive nephrectomy if the patient has got a small kidney masses with florid metastasis, if his performance status is not good, and and these are the places where I'll not start. I'll send it to medical oncologist for target and immuno, and if he responds well to these treatments, he can further later on come for the cytoreductive nephrectomy. So you have to see the performance status, you have to see the primary bulk of the disease, you have to see the local symptoms. These to be seen before you take a call for cytoreductive nephrectomy.
Okay, then. Thank you.
So, Dr. Awal, can I say that before making such a decision, it is better to have a combined discussion on
Absolutely,
the patient,
absolutely.
especially because once upon a time we used to refer that let the cytoreductive surgery done for metastatic, then we take care. Now the things has changed, so we need to discuss in a combined way, then to proceed. No more that surgery is the upfront treatment of cytoreductive surgery. That is the message for the student.
Yes.
Dr.
Okay.
Menon, Dr. Menon, you can ask directly. You can ask the question. Dr.
Sir,
Menon, yes.
Assalamu alaikum, sir.
Also,
Sir, what is Housefeld unit and how to interpret the Housefeld unit in case of renal cell carcinoma, sir?
Yeah, it's actually Housefield is the name of the person who made this CT scan. He got Nobel Prize after, I think, 10, 25 or 15 years. And on his name, the Housefield unit goes, and I'm not a radiologist, but then I can say that if the contrast enters into the tumor, the Housefield unit increases. It depends on how much is the contrast as well. If the Housefield unit tissue tumor, soft tumor is the soft tissue is there, which is enhancing. So any enhancing mass in the kidney is taken as tumor until unless proved otherwise. So this is classical, Hounsfield unit is for cyst is separate, for kidney, normal parenchyma is separate. For tumor, if it is enhancing and this is going up, this means there is a soft tissue mass, and this patient has to have treatment for this. You just can't ignore that.
Any more question?
Please clear about the nephrectomy.
Say that again, please, Dr.
suprarrenal gland during
Huh.
nephrectomy. What's about suprarrenal gland?
Classical radical nephrectomy in 80s used to be that you have to take out the perinephric fat and renal gland of that side. But later on, there a lot of paper in 90s came that not many people were removing the adrenal gland. And slowly, then when the understanding increased, then the role, the exact indication developed that when you have to remove the adrenal gland. And nowadays, adrenal gland is removed when there is upper pole tumor, big tumor upper pole, and you are doing the radical nephrectomy. You must remove the adrenal gland. Otherwise, if that is mid and lower pole tumor, there is no need to remove the adrenal gland nowadays.
Thank you, sir. Thank you. We are at the last part of our session. Just we have designed a quiz competition from the taken from the Professor Rawal's lectures and the discussions that we have made today. So a quiz competition was made from them. So now, dear students, please participate in this quiz competition.
Dr. Azad, can I leave tomorrow? I have to work tomorrow. So can I leave now? This my I actually sleep early, get up early.
Yeah. Sure. So thank you.
Don't worry, I'll be here.
Now, Dr. Salam is there. He's
I'll be compensating
yeah,
your
sure.
absence.
Thanks a lot. Thanks a lot, everyone.
See you.
They're
So
really
I'll,
to you, and we'll invite